So I'm just going to breeze through and hopefully, everybody would understand what I'm saying. Anti-phospholipid antibodies from bench to bedside. Let's look at this 30-year-old female, 16 weeks pregnant with SLE. And you get a phone call. I have become pregnant. I'm taking Plaquenil. And the next question from the rheumatologist, which is generally asked, is, what is your anti-cardiolipin antibody status? And she says, positive. So what do? So at the end of the talk, all students especially and PGs should be very attentive, because I'm going to ask that question and you're going to answer for me as to what you're going to advise to this panic-stricken lady who's pregnant for the first time. Okay, so anti-phospholipid antibodies, what are they? They are one of the most commonly acquired causes of hypercoagulability. They predispose to both venous and arterial thrombosis. Venous thrombosis is generally 3 times more common than arterial thrombosis. So mostly venous thrombosis and arterial thrombosis is less common. More so what you would see is like DVT, pulmonary embolism, TIAs, and thrombosis almost in any organ system of the body. And one another important feature of these antibodies is that they predispose to miscarriages and other pregnancy-related morbidities. So patients who have antiphospholipid antibodies, the syndrome could be primary, in which there is no underlying connective tissue disease. But it is associated with other features like thrombocytopenia, like livedo reticularis, vegetations on the cardiac valve, mitral valve prolapse. But about 8% of these primary antiphospholipid patients develop SLE later on in their course of life. And then there is a secondary antiphospholipid antibody syndrome, and this is really due to an underlying connective tissue disease, and mostly it is SLE. About 40% of the patients with SLE in different studies have shown to have antiphospholipid antibody. The common antibody which is present in their serum is anti-cardiolipin, but 25% of them have a lupus anticoagulant also present. What is the clinical spectrum of this? So, antiphospholipid syndrome is a disorder which is characterized by a wide variety of clinical manifestations. And virtually any organ system or tissue may be affected by thrombosis of large or small vessels. So you could have a young patient in the emergency room presenting with stroke or with history of TIA, or a young patient whose first time presentation may be an MI. So it is generally recommended that if you have young patients with MIs or young patients with stroke, you are obligated to check their phospholipid antibody status. And what is the nature of these antibodies? They generally bind to plasma proteins and they have an affinity for phospholipid surfaces, and that is why they are called anti-phospholipid antibody. And they are responsible for thrombotic events and also a risk factor for recurrent pregnancy loss and obstetric complications. 3 most common antibodies which can be detected in the sera easily are anti-cardiolipin antibodies, lupus anticoagulant, and beta-2 glycoprotein 1. But there are others also which we don't need to name because they're very difficult to measure. So what is, how do you classify antiphospholipid antibody syndrome? Again, I will emphasize over here that you don't have to strictly adhere to a classification criteria because they are meant for research purposes, and it's the judgment of the treating clinical physician actually to make a diagnosis. So generally, one clinical criterion, which is thrombosis, either arterial or venous, or thrombocytopenia, and a pregnancy-related morbidity. And what could that be? 3 or more first trimester losses. And it is very interesting that our gynecologists in Patna Memorial Medical College and Hospital, where we work, are very attentive to this problem, and we usually get referrals from them when they have patients who have recurrent abortions. So the gynae people should be on the lookout for such patients. One or more late fetal losses, or preterm birth due to placental insufficiency, or 3 or more embryonic losses which are less than 10 weeks of gestation, which are unexplained by chromosomal or hormonal causes or any anatomic causes. And we should also remember that the presence of APL antibodies has to be on 2 or more occasions, which should be at least 12 weeks apart. And you have to have one laboratory criterion out of these, which is the presence of lupus anticoagulant and moderate to high titer of IgG or IgM anticardiolipin. What I think a poor man's test could be a VDRL test, a false positive VDRL.